I think this part now is the interesting bit. It's time to ask questions. It's time to interrogate and bring our speakers up to the panel. What we're going to do is I'm going to stop the screen share, and I really do sincerely apologise for our technology. This is a low budget operation, but we've got a couple up here. I think we'll just start with these guys, and we've got questions as well that could come through to Kerry. So the format is I'd love to ask you guys if you have any questions first. Then we've got some prior questions, and then there's questions coming in online. So could I ask the guys in the room if you have any questions? I'll repeat it so people online can hear it, and then I'll ask you guys if you've got a mic to hold one. We'll find one. I'll pass this along to you. Yeah, no worries.
I've got one for the audience. I'll pass it
around.
Oh,
yeah, you've got one. Okay, fantastic. So does anyone have any questions? Please.
Thank you. These questions are actually from my daughter, who has PSC. She's 13. She did ask this afternoon, does having PSC always end in liver failure?
So not commonly in paediatrics is the answer to that. So I'm going to defer to Kate for that. So most of our PSC patients, we hand on to adult gastroenterologists, often in reasonably good health, hopefully, and we breathe a sigh of relief and we say good luck.
I've never been able to find in the literature an exact percentage of what percentage of people with PSC end up with a liver transplant or die from PSC. But it's not more than 50%, definitely not. So it's definitely doesn't always end in liver failure. It is a significant proportion of people. I don't have an exact percentage, but the answer to your question is no, it doesn't always lead to liver failure. People can have symptoms that affect them their whole life without ever having their liver stop working, such as tiredness, pain, etc. And I have a lot of patients who are really well. And I think I don't work in a liver transplant centre, so I don't see that pointy end as much, but I do see a lot of patients. So no, it doesn't always end in liver failure. Thank you.
I think that's a resounding no. I can agree with that as well. I think you can go home and tell your daughter resoundingly that is not the favourite.
She also would like to know if you can drink alcohol with PSC.
Well, that's a curly one.
Push it out the door.
Well, I look, I'll have an initial crack at it, then I'll pass it on to these guys. I mean, I think depending on the stage of PSC, I mean, certainly if you've got a normally functioning liver and you're drinking within moderate guidelines, I certainly think that life is to be lived, but I'm sure there is a different perspective that comes from someone who drinks alcohol. So maybe I'm projecting the wrong message, but I think we're all humans. What do you think, Kate?
I tend to tell people try not to drink it. I say you can't, I don't say you can't ever drink it, but I say save it for very special occasions. So I don't actually recommend you just go with the guidelines, 10 standard drinks or less per week. I say try and avoid it altogether, and just the occasional odd drink for special occasion is not going to hurt you.
Okay. Well, obviously not.
No, she's looking ahead. Sorry.
Well, we do deal with this. We deal with 16, 17, 18-year-olds. So generally I tell them to be sensible, to be careful, particularly those people with liver diseases. I say basically the less you have, the better it is. Now, the occasional single drink to celebrate something is probably not going to do you any harm, but significantly more than that, the more significant the chances are that it's going to help you. So not no, but be sensible is my advice.
And I'll just throw something on that. But in terms of, no, keep it to you guys, or maybe you can't yet. No. Paracetamol, it's come over the question line. It's similar to alcohol. It's something that is common. Can people with PSC have paracetamol?
Yes. So
I think that's another
unless you have advanced liver disease with cirrhosis, you can have normal doses of paracetamol. Okay. That's another question I had. Actually, so well done. 1 gram up to 4 times a day, at least 4 to 6 hours apart. Yeah.
sorry, I know it's not a question, but I've had it since I was 13, so that 17 years. And when I first got it and was getting, diagnosed and everything with it, I got told to have significantly less Panadol, to the point where, basically maybe one capsule, if that, but try to avoid it. And yeah, so that bit of information. So is that something that's been found out more recently? I will put a question into it. There we go. Is that something that's been found out more recently, or is that just something that I was missing?
I think it has to be applied to the patient. And if I have someone who has advanced scarring, which we can do with things like FibroScan, liver biopsy, then I do recommend only having it occasionally, 1 dose max per day, occasionally 2 doses max. So it does depend, but if you don't have advanced scarring, you can have it normally. But if there's a lot of scarring, then yes, we do reduce it.
So if I can add on that, what are the best pain medications then that aren't really liver effective, if there is one? Then yeah, it's something I've struggled with a lot through my life, is pain medication, because there's so many things I've been told, you can't take this, you can't take this, and the stuff that I can take doesn't work half the time.
So that's a very, very, very difficult question, and I note that Kate was really quick to hand it over to me for that. So yeah, look, so certainly for us, giving permission to use paracetamol in normal doses is something I frequently do. I get phone calls from doctors, not necessarily gastro or liver specialists, but from doctors at the hospital, saying someone's liver tests are off just a tiny bit, we can't give them Panadol. And it's like, yeah, you can. So permission to use the right drugs. Nurofen can have a bleeding risk, but I don't think that bleeding risk is significant unless you're, again, at that really advanced pointy end of things. So
that's what I was going to.
Yeah. So so that's exactly right. So then there's another. We all like to not quite avoid, but almost completely avoid the opiate type medications. I mean, I think for people who've had an operation who are going to use it for a day or two or something, sure, no problems. But for a more, so then I think we're looking at more chronic pain medication, and that is a specialty in its own right. I mean, low dose antidepressants is something that I use for people whose pain is more chronic. Some medication called Periactin or cyproheptadine. It's probably more for functional gut problems. So that's my experience with it, but it's tough, and I'm going to hand it right back to Kate.
Yeah, I'm not going to add much. I mean, I normally say IBD, don't take NSAIDs, ibuprofen. And yet, if I've got someone with rip-roaring joint issues and it's going to give them much more quality of life, then even though we recommend not to take something, you have to balance against what it is they need it for and what is their quality of life. So we'll always say, don't take this, don't take that. But it is a matter of also taking everything into account. So there's recommendations not to take certain things, but nothing's ever blanket, I don't think.
And I think with anyone with complex pain, something I would say is actually to go to a complex pain management clinic, because as you say, it is a specialty in its own right. So somebody also pointed out here that they may need the paracetamol to help with the headaches after they've had their alcohol.
There's a simple solution to that.
Some really good questions about pain. I've got a question I could ask here that maybe I'll ask it to Kate first. Are there any natural therapies that you'd recommend for PSC? I think that's quite a common one, the over-the-counter options. Are there any that you'd recommend?
Oh, I'm asked about probiotics a lot, and I don't know if DJ is going to cover that or not. I'm not aware of any really good studies of probiotics. I'm asked about milk thistle and various liver detox type things. And there's actually a really good podcast called The Liver Pod, I think it's called. It's by 3 Aussie guys over in the eastern states, and they talk about liver tonics in it, actually, in liver cleansers. It's a really good episode. And really, they're not proven and don't have any data behind them. They make people feel good. So I think coffee, I think Alice is probably going to talk about coffee. No, coffee has been shown to be beneficial in a lot of liver diseases, including PSC.
It's a good news story.
And there's something about and that's not a natural therapy. I don't know if it is or not, there's something about the coffee. It's not present just in caffeine tablets or tea, and even, 3-4 cups a day. So if you can tolerate coffee, I encourage coffee. And I tell all my patients about coffee. Hopefully I do. Yep. Okay. And I think I just generally say, I don't think there's any herbal or things I'd recommend necessarily that have been shown in PSC. A good diet, and Alice is going to talk about that, staying healthy, exercise, and just monitoring, really. So I don't have any special natural therapies.
I'd echo that. I think there's a lot of things that are marketed to people with illnesses, and don't take it if it doesn't make you feel better. But if it does, and it doesn't break the bank, perhaps there's benefit for you individually. I think that's the take home, particularly with things like probiotic, which have an extraordinary marketing mechanism behind them. The evidence is not as it stands, despite our excitement about microbial change in this illness. Are there other questions coming in? Otherwise, I can ask a provocative question. Do you need to see a gastroenterologist and a liver specialist if you have PSC?
I'm not sure if this is working because I pressed the button and all the lights are on now.
Everyone looks to DJ.
Okay. Look, I think you probably do. I think in the pediatric world, generally the gastroenterologists are both hepatologists and luminal gastroenterologists. But increasingly in gastroenterology, people are subspecializing down silos. And Rob's an IBDologist, the gastroenterologist, and doesn't do really much hepatology these days. But he knows a lot about PSC, but it takes a huge amount to keep up with the intricacies of PSC. And I think even a lot of hepatologists don't know all the intricacies of PSC. So personally, I think the hepatologists definitely don't, as a rule, know all the intricacies of IBD. So personally, I do think you need to see both hepatologists and gastroenterologists. That's my opinion. I think that's difficult for the person, that they have too lots of appointments and they may have too lots of gaps they have to pay if they're doing it privately. I don't think it's very common that people specialise in both.
There's not many one-stop shops, but
yeah.
Thanks, Kate. Yeah. That's really good.
But hang on, I think Terry's.
We do have another question coming from our online audience, which I think might be relevant to quite a few people, about PSC and pregnancy. Can urso still be taken when pregnant, and will the symptoms worsen? So just, a bit of a conversation about PSC in pregnancy.
I have many patients become pregnant, and lots of PSC patients who've had really successful pregnancy.
Me too.
Urso is a drug given to people in pregnancy for another bile acid condition, and it's definitely safe in pregnancy. I would thoroughly recommend staying on it because people with PSC are more likely to get bile salt, bile acid complications in pregnancy, which we treat with urso anyway. Unless you have very advanced disease, such as cirrhosis or decompensated cirrhosis, then there's no reason why people with PSC's fertility or ability to have a child should be impaired. If you do have advanced liver disease like cirrhosis, there's extra monitoring and extra risk, and that should be discussed with your specialist before becoming pregnant.
The question I think that's come through, this is flashing now, but it relates to symptoms and the correlation between symptoms and what's happening inside your body. And I think that's a really hard thing for anyone to judge. If I'm feeling fatigued or if I'm symptomatic, what does that mean for my PSC, and what's the correlation between those two things? And that's a source of anxiety, and understandably so. It's a really difficult question to ask, but I think, Paul, you're the right guy.
I'll briefly touch on it and then hand over. So I think in general, people with the more severe disease will have more severe symptoms, but that's a very big generalization. I often see people where you objectively look at it and their disease can really be quite mild and their symptoms really quite severe. And you can see the other end of the spectrum as well. You can see people who actually objectively have really quite severe disease and their symptoms are mild. So whilst I think there is a trend where they're matched, I think it's a very vague trend anyway. That's just my impression.
There was some data from about 20 years ago to suggest that having symptoms was a poor prognostic sign, and that hasn't been borne out in more recent studies. And there is this disconnect. And so I also think with fatigue and lethargy, it's so important not just to say that's just the PSC and make sure that other causes of tiredness are ruled out. So I'm pretty hot on iron studies, B12 studies, vitamin D, thyroid function, all of those things. But inflammation makes people tired as well. So having inflammation in your bowel or your liver, even if it's not advanced, can make people tired. So the clear answer to that question is there's this huge disconnect. And I don't think that being really, really tired or having abdominal pain means your PSC is really severe and more likely to progress as a rule.
It's a really difficult thing to address, though. It's hard not to internalize if you're experiencing those symptoms and you tie them to a condition that you've been told is incurable. But I think having that objective marker alongside and a rapport with your specialist or your nurse or your treating person is really important to disentangle that connection between what you're experiencing and what may be happening. I'd like to ask Kerry a question, if that's all right. You happy to get dragging her from behind the? Do you want to sit up there, or is that too?
I'd love to.
I really thought, because
Delighted.
we're in the setting here of, I just love the talk before about empowering yourself or your family. Like, what can you do in this setting? What can you do for yourself, and what information sources should you be seeking? And what can we do broadly for this area in terms of advocacy in a rare disease? That's a two-part question. Sorry, Kerry.
That's quite the question.
Yeah, it is, but you're...
Look, I think a couple of the key things that I found for me, myself, education, learning about it to whatever capacity I could learn about it. So, I don't have to have the same knowledge that Dr. Kate's got, but I can talk to Dr. Kate with what knowledge I've got and we can work it out together. So it is that learning to whatever capacity you can, and it's ownership. And it's you taking charge of it, not letting it take charge of you. If you don't look after yourself, it will let you know it's around. It will come and bite you. If you take charge of it, you're going to give yourself such a better chance for that not to happen. So I would, say that learning yourself and taking that control and doing the monitoring, going to the doctor. Is it a hassle going to a doctor's appointment? Yeah, you bet. I get that, but there's benefit in it. So you've got to, if you engage with the treating team, you go to the doctors, you do the tests, you've actually got much higher chances. And Dr. Kate even indicated that in people who have that monitoring and that ongoing MRCPs, they fare better. They just do better. So I think that's a big part of it. Having a conversation with your specialist and asking questions. If you go in and demand something, you're not probably going to get what you're demanding, and you're not going to get a good conversation. If you go in and say, I've been reading about this, what do you think? How might that fit in my case? And have a conversation. There's very few doctors that would then get their backs up at that and not want to talk to you. Most of them would say, oh, okay, let's unpack that together. And sometimes you might even learn with them at different levels as well. So,
Karen, you mentioned information and being informed, but we've been told there's some websites. Where do you get your information?
There are some interesting websites. And look, I've got to say, 24 years ago when I started looking and there wasn't websites and I was just getting journals, I think, go to your key websites, we've got some good information on our website. We've even got some coffee information on our website. One of the doctors that spoke a couple of years ago, that's his absolute passion. He loves his coffee. Dr. Alex Hodge, he's all about coffee. The UK PSC group have also got really good information on their website at our PSC partners in the US. So there's a few really good websites. When you're looking at information, if something that you read is different to everything else you've read, it's possibly wrong. Somebody didn't suddenly find the cure for something, and that's the only person that knows about it. So I think that's a good thing. But yeah, really think about your websites. If you're wanting to look a bit deeper, looking at things that say peer review journals, that's helpful. Something that somebody's just written in a blog is their experience. And that can be helpful in one sense, but it's not the medical, and that's where you might get some different information. So stick to your main websites, check back into the source of truth on those websites and your source of truth with your doctor. I read this on the internet, doesn't seem to fit with what I know. What do you think? And get that unpacked with the doctor as well, can sometimes be helpful.
Thanks, Kerry. That's a great answer.
I might just mention Twitter is a great source of the latest info, but if you know who to follow. So it's called X, sorry, X. I mean, Kerry with PSC Support Australia tweets lots of things.
No, we've got no.
Oh, you've got.
It'll be
it's on Facebook. Yours. Or?
Yeah, ours is Facebook.
Gideon Hirschfield is one of the world's best PSC doctors in Toronto, and I can't remember what his handle is, but it's Gideon Gideon Hirschfield Hirschfield, and he's a prolific Twitterer or Xer. I tweet. I'm at .Kate Lynch, and Palak Trivedi Trivedi tweets a lot, and you can see who they're following. But once you follow one or two people about PSC, all the tweets, X's start coming up. And I actually learn, I hate to say it, but I actually learn a lot about what's happening out there in research world from Twitter.
The algorithm will find you.
So
I suppose I'd just like to finish on the last question. I'll address this to Kate really, but you covered some data and we've gone through, it's really optimistic that there's a raft of trials. It's positive to see things like keeping up with MRCP monitoring doesn't influence your prognosis. But that's discordant with the message that you get when you're diagnosed and the blog that comes up about, sort of the horror and the sense of helplessness. Are we heading in towards an era of better prognosis? And I think,
I think so. I'm hoping in my lifetime, I'm definitely thinking there will be a medical therapy that slows the progression. Ideally, my goal would be to be involved and somehow a cure for PSC, but I feel very hopeful that within the next 10 years, hopefully sooner, we'll have a drug that slows progression. And I mean, even anecdotal things, that noracolic acid, I had a patient who said he found a spring in his step he never realized he'd lost. And I found out he was on the highest dose of the drug. And I just feel, and I think the patients who go in clinical trials are amazing. People with PSC are so educated and involved and they want to help. Bradley's a perfect example of that and his motivations. And I had people come from all over England writing to me, asking for me to stick a needle in their liver so I could take their liver cells to the lab. And I was blown away by it. So I feel like it's such a collaborative effort, not just from researchers, but patients and caregivers. And I feel quite excited about the research. To be honest, I wasn't as excited about Carlifex or the drug that failed. And so it wasn't that surprising to me that it didn't work. I'm more excited about some of the other mechanisms of action.
So that's an optimistic finish. Thank you, everyone. I'd like to put our hands together for our speakers for that first session. Thank you so much, Brad. So we'll just probably take a 2 or 3 minute break to reset. If anyone needs a drink or something to eat that's here. For those online, if you're able to take a break as well, around 3 minutes, and we'll take on with the second session, which is exciting, and we're looking at microbial manipulation and PSC. So we look forward to that. Thanks.